Hello and welcome to the first of a series of podcasts on orthopaedics. In this introductory podcast we will cover general principles of naming bones, describing fractures and a couple of classifications to be aware of. Firstly, a quick revision of the skeleton. I will not cover gross anatomy and would recommend a decent revision of pertinent anatomy before starting any surgical attachment. Students are often asked anatomy questions in theatre, so it is worth preparing. The adult human body usually has 206 bones, although this can vary depending on fusion of small bones. This breaks down into 30 in each limb, plus 2 fused in the pelvic girdle, the clavicles, the scapula, and the axial skeleton, which consists of the sternum and 24 ribs, the 26 vertebrae, the hyoid, and 28 in the skull, 8 cranial, 14 facial, and 6 in the ears. Now these 206 bones show a wide variety of structure and function. Bones are usually put into 5 groups. These are long bones, short bones, flat bones, irregular, and sesamoid. Long bones are typically tubular and include the femur, radius, and phalanges, important for support and locomotion. The short bones are your cuboidal tarsals and carpals. Flat bones, such as the cranium, ribs, and pelvis, typically have protective functions. The vertebrae are an example of irregular bones. Finally, sesamoid bones are those which develop in tendons, such as the patella. As an aside, there can also be accessory bones, a normal variant which develop from additional ossification centres, and heterotrophic bones, which is a bony formation in soft tissue secondary to repeated trauma. The most well-known heterotrophic bones are those that can develop in horse riders' thighs, known as Prussian's disease. The skeleton is not just for structure, support, and locomotion. Bone marrow is an important site for hematopoiesis. Bone is an essential in salt acid-base homeostasis, particularly calcium via vitamin D and parathyroid hormone. One last bit of background and terminology to cover is the naming of parts of bones. Imagine holding a femur in your hand with the hip at the top and the knee at the bottom. The femur is a long bone. The shaft you are conceptually holding is called the diaphysis. The ends are called the epiphysis, and the shaft that widens towards the epiphysis is called the metaphysis. After birth, the bone grows at either end from the epiphyseal plate, which separates the metaphysis from the epiphysis. Bone is made up of both cortical and cancellous bone. Cortical, or compact bone, forms the majority of the skeleton. It is dense and designed to resist compression forces and provide rigidity for the attachment of tendons and ligaments. The diaphysis is mainly cortical bone. Cancellous bone, also known as trabecular or spongy bone, is less dense. It makes up the central mass of bones and is the predominant bone in the metaphysis of long bones. A few definitions on fracture terminology. A fracture is a partial or complete disruption of the cortex of a bone. A dislocation is the complete disruption of a joint. A subluxation is the partial disruption of a joint. The first thing to remember about fractures is that in a traumatic fracture, the injury is not limited to the bone. There may also be extensive soft tissue injury to nerves, vascular supply, and skin. Identifying neurovascular damage is an essential part of any musculoskeletal exam. The force required to break a bone may be direct or indirect. An abnormal bone may fracture under a normal load, which is called a pathological fracture. Or a normal bone may be fractured from repetitive normal loads, which is called a fatigue fracture. Bone has defined mechanical properties, therefore patterns of fractures are predictable if the external forces are known. For example, a twisting force will typically cause a spiral fracture of the bone, and high energy impacts will cause more complicated damage, resulting in more comminution or fracture pieces. The structure of mineralized bone makes it stronger in compression than in tension. If you think of a football player, when he is running, a force of around 3 times his body weight is transmitted from his foot up through his tibia, but he could run all day. However, a misplaced tackle by an opponent's foot with a similar force but perpendicular to his lower leg, and he won't be running again for a while. Now, invariably, at an early stage of an orthopaedic attachment, an X-ray will be thrust in front of your face, and this is how to describe it. Firstly, the background information, which also serves as some thinking time so you're not left with a mute stare. The relevant background is the patient details and the film details. For example, this is a plain radiograph of the right femur of Mr. Smith, 58, taken on the 1st of April. In some circumstances, it may be reasonable to ask if there are previous films for comparison. For the description, there is a specific order you will expect it to use. This is comminution, type, location, and displacement. For type, start with whether it is a simple or comminuted and a closed or open fracture. Simple, 2 pieces, or comminuted, more than 2 pieces, which may be mild, moderate, or severe. An open fracture is when the skin is breached, and this may only be seen on clinical examination rather than on X-ray. Now, the type of fracture is a description of the line of the fracture. This may be a transverse, oblique, spiral, impacted, hairline, or green stick or buckle in children. Location is the name and part of the bone, and whether it is articular, metaphyseal, or diaphyseal, or in a characteristic part of the bone, for example, the neck of femur. Next, displacement. Displacement, by convention, describes the distal in relation to the proximal fragment. Fractures are either displaced or not displaced. If they are displaced, then this is described in terms of translation, which can be expressed as a percentage of the bone width, medial, lateral, anterior, or posterior. Or angulation, the degree of angulation from normal, or shortening in centimetres, and rotation. So remember comminution, type, location, and displacement. And also remember to look for dislocations and subluxations. Finally, comment on the soft tissues. You may see edema or disruption of usual alignments. For example, in the elbow, an abnormal fat pad visible on X-rays posteriorly indicates a 90% likelihood of an intra-articular fracture. In knee injuries, you may see a lipohemarthrosis, which is fat and blood in the joint. Take this slide as an example. This is a radiograph of the upper right leg of Mr. Smith, 58, taken on the 1st of January. It shows a femoral fracture. This is a simple oblique, non-comminuted fracture of the proximal diaphysis of the right femur. It has medial translation, 45-degree medial angulation, and 1 centimetre shortening. And if this was a properly sized image, you could look at the position of the knee to determine rotation. The second example could perhaps be our imaginary footballer who took a slide tackle to the shin. So let's say this is Mr. Bloggs, 28. This is a radiograph of the left lower leg of Mr. Bloggs taken today. It shows a tibia and fibula fracture. The tibia fracture is a simple transverse mid-diaphysis fracture with 80% lateral translation, with no obvious angulation, shortening, or rotation. The fibula fracture is comminuted with transverse fractures and 50% lateral translation of the segment. Now, something along those lines should suffice. Different consultants and departments will have different views on exactly how it's done, but this is a good starting point. Describing a fracture is a tool to convey the severity and nature of an injury to an orthopaedic surgeon over the phone. Finally, for paediatric fractures involving the epiphyseal plate, you should know the Salter-Harris classification. Damage to the epiphyseal plate can affect bone growth, and the Salter-Harris classification of these fractures has a prognostic value and will influence treatment decisions. There is a useful mnemonic for remembering these fractures. Now, firstly, imagine all fractures are at the inferior end of the bone, and the mnemonic is SALTR, Salter. S, type 1, is slipped. The fracture separates the epiphysis from the shaft. A, type 2, is for above. The fracture line runs above the plate, usually with a triangular fragment of metaphysis. L, type 3, lower. The fracture line runs below the plate, so the fragment is part of the epiphysis. T, type 4, through. The fracture line runs through the epiphyseal plate, giving a fragment of metaphysis and epiphysis. R, type 5, rammed. The ends are rammed together and the epiphysis is crushed. So, in summary, remember a fracture is not just an injury to the bone. Look for and comment on injuries to joints and soft tissues. And when describing a fracture, comment on which bone is affected, whether this is open or closed, and then the comminution, the type of fracture, the location, and any displacement. Thank you for listening, and check back soon for more orthopaedic podcasts.